Recovery Reform is a podcast that provides educational content while addressing the stigma against drugs and the people who use them. Expertise meets lived experience as the hosts and their respective guests unpack the multifaceted cause that is recovery reform. Hello, welcome back to the Recovery Reform podcast. I'm here with my co-host, Dr. Taylor Nichols, and we are going to talk about stigma. Specifically, we're going to talk about stigma within healthcare, and we're going to talk about stigma within the recovery scene, whether it's like recovery communities, online, within treatment, like all of that stuff. And so I guess we'll start off with healthcare. Taylor can kind of talk about his experience with that, you know, as a medical professional, and then I can kind of share my experience as someone who had a substance use disorder and, you know, experienced different forms of treatment. Also someone who has chronic pain. So that's something we can kind of, I guess, briefly touch on as well. But I'll give the floor to you, bro, and we'll just kind of go back and forth.
Thank you for that, Collie. And you have the experience across multiple spaces, multiple communities to be able to talk about that. And I appreciate that this is sort of what we're going to talk about today, because it is one of my favorite topics to talk about, because it is probably the single most important thing that I would want to get across to people to understand, both, you know, people who are struggling, people who are seeking recovery, who are in these recovery communities, and to other physicians and other, you know, health professionals, because it is very much an issue within healthcare that needs to be addressed. And that is how I got into this space to begin with. You know, you've heard me tell this story before, but I was not a harm reductionist when I went into medicine, when I started medical school. That wasn't sort of my mindset. And I was raised much more in the sort of typical culture, but also like the AA kind of Al-Anon mindset of, you know, that this is a chronic disease and that the only approach is abstinence. And so, you know, they really approach it as like harm reduction can't work. And so I kind of felt that way going into medical school. And it wasn't until I was in emergency medicine residency. And I did my residency at UCSF and San Francisco General. And particularly at San Francisco General Hospital, you know, it's the only county hospital in San Francisco, and we see everything and you treat everyone. And it was kind of an honor to be able to feel that and have that perspective of like, this entire city could be my patient. All the people of the city are my patients, right? And you see the, you know, unhoused folks, you see people with substance use disorders, you see people who use drugs, whether or not they have a substance use disorder, frequently. Some of those people become your regular patients who, you know, we would call them like friends of the emergency department. And as frustrating as some of those patients could be at times, we all started to care about them. And it would be like, oh, hey, I haven't seen Tim in a while. You know, you see him recently? That sort of thing. Because even when they come in and they're drunk and angry or whatever, like, you kind of start to see them often and recognize them out on the street, and you care about them. And while I was in that, I started to see where my perspective was wrong, where harm reduction really was pretty key in improving people's lives, and taking sort of more compassionate approaches was the most helpful thing towards just having these people feel seen and listened to and heard by a system that regularly did not see or hear or listen to them. And they often felt mistreated or abused by the system. And I like to say that the only rational response to being a part of a system that is causing harm is to seek to reduce that harm. And that's how you land specifically in harm reduction. And so as I recognized that over time, my goal became to try to perpetuate that idea within healthcare, And if I heard my colleagues saying things about patients or saying things about substance use disorders or people who use drugs, I would correct them or I would challenge them and say, well, what do you mean by that? And tell them that these are patients who should be treated with dignity and respect, just like any other patient, but also to recognize these conditions. So there would be times when, Macaulay, you mentioned specifically chronic pain, right? We would often have chronic pain patients who came in for acute pain or when their chronic pain needs weren't being met. And people understandably, end up getting frustrated with the idea that people are coming to the emergency department, they're seeking opioids or whatever. In my mind, I would always remind people that people are here to seek treatment. They're here to seek care. And sometimes that involves opioids, right? But you'd have, in my mind, I learned to be able to let that frustration that people might experience, let that roll off my back and just say, I'm here to take care of that person, regardless of how I might feel about their care need, right? A huge example is we had a number of sickle cell patients who would come in with pain flares. And it's like, hey, guess what? This is a really painful condition. Have you ever had a sickle cell crisis? If you're judging them, I don't know, maybe consider being in their shoes and treat their pain early, not just deny or delay, but specifically jump on it. To the point where I started being an advocate for using intranasal fentanyl for patients as soon as they were able to get into a place, right? People have to be monitored, et cetera, but we're doing a lot of waiting room medicine. Say if we can put them in an observable place, even in a chair, have what we call vertical internal waiting room or vertical beds, then put them there and give them intranasal fentanyl to treat their pain. And so, you do start to see the harm that's being perpetuated, the harm that is being caused to chronic pain patients, to people who use drugs, and to people with substance use disorders who are seeking treatment, sometimes unrelated to their substance use disorders, but when they're seen as just a person with a substance use disorder, their other things are also marginalized. Their other conditions that they're seeking care for are marginalized. They are marginalized as people. And we can improve upon that within healthcare. And I encourage every healthcare professional to seek to understand that better and to learn about how to even just talk to people about using drugs. I have medical students and residents and fellows rotate through my clinic, and I always say that if there's one takeaway, I just want them to all have the experience of and learn how to feel comfortable talking to people about their drug. We have new patients come in and talk about what are they using, how are they using, are they injecting, are they smoking, are they snorting, and talk about their experiences with drugs, because that's pretty important in terms of being able to treat them, right? And so regardless of what field of medicine they're going into, if they're, say, a medical student, it's important for them to still be able to talk to patients about using drugs. Doesn't matter, right? Lots of people, regardless of what need they come in for, use drugs. So that's a critically important piece of just humanizing that aspect. And then the other part that I want people to understand is that there are also medications that we use to treat people so that they're able to improve and seek their goals, right? The goal of harm reduction is any positive change, and trying to meet their goals, meet people where they are. And so we can help them meet those goals. And it doesn't have to be what our goal might otherwise be for them. It doesn't have to be abstinence, right? And that's one of the things that you and I have talked about in terms of the harms that the recovery community causes to people who are in recovery or who are seeking recovery is this idea of sort of perpetuating projecting a specific goal onto people. abstinence only or what have you, or that they can't be on medications even, right? So that's the other part that I think is critically important. But I do want, and if there are healthcare professionals who are listening, like I do really want people to sort of try to maybe approach it with a little bit of humility and understanding that we are often wrong about things like this. And it does take a little bit of humility to sort of understand what we don't understand and then improve upon that, because we can do better, but we just don't know. Not a lot of us have substance use disorders or overcame prior use, right? Um, and so we don't have that perspective. And without that perspective, we often miss in our approach to treating people who do.
Mm.
Which could be said for a lot of things, but in particular, things that marginalize people, right? That minoritize communities and allow us to see folks as different or less than and treat them in that way. And so I think this is a really important point that we are not just causing harm to people who have substance use disorders or people who use drugs, but also to chronic pain patients and people who deserve treatment, which is everyone deserves treatment, but in particular, people who have chronic pain also specifically deserve to be treated for acute exacerbations of that pain or unmet needs. And you could argue that people with substance use disorders who are coming in for harms caused by those substance use disorders, whether it's intoxication or withdrawal, those are also unmet needs. And we should try to meet those needs as best as we can. And it's something that's not taught to us, right? In emergency medicine, we're taught like how to do everything else, how to do procedures, how to treat people who are literally dying in front of us. And the one thing we're not really taught well is like how to meet needs of people who have unmet needs where the system is failing. We're like, we could approach that person with an opioid use disorder better and like offer. Their goal may not be to like get on treatment like buprenorphine yet. Be like, hey, there are treatment options. Are you interested? Instead of just like treating them poorly, trying to move them along, right? So I think it's critical that people sort of reassess their perspective, and that the abstinence only mindset, that learning about harm reduction and approaching things with a harm reduction framework is the only way we're going to move forward, including for the chronic pain community, including to improve care for them, and including for people in recovery, within recovery spaces. Because, and you can speak to this better than I ever could, but because that does cause harm, and it does cause an internalized shame that people feel when they are seeking recovery or they're in recovery, that I think is problematic. I don't know, what do you, in terms of your perspective from the recovery side, like what do you see as the harms that are sort of perpetuated on people who are in or are seeking recovery?
Well, I definitely want to acknowledge, like, within the medical space, just what I've observed and experienced. And I can kind of give perspective on, a potential approach that could help providers, honestly, because I can give you some insight, into my own experience. And then, just things that I've kind of hyper focused on in the past couple of years. And I can kind of segue into, just like the recovery space as a whole. But I think it's really important to mention three things. First of all, paternalism, which is found a lot within the medical space, because we're dealing with people who genuinely and generally have pretty good intentions for the most part and care about people. And so that can then bring about this kind of authoritarian mixed with kind of paternalistic way of communicating. And so I think it's important to, if you're going to engage in either of those things, to do that with a harm reduction mindset as opposed to a complete preventative mindset, punitive mindset, or just this kind of idea that you need to kind of dictate what someone does in their own life. But it's very tricky when you're dealing with like medications and like protocols and laws and like all of this other stuff. And so it's like, I imagine that's a tightrope to walk, and to balance that. But if I could offer, unsolicited advice to like any medical professionals, it would just be like, hey, like, just consider that you don't need to be this like paternal figure. You can, be very compassionate and understanding towards someone, but also acknowledge their autonomy at the same time. And a lot of it ties into like bedside manner, to where it's like, so the three things I was going to mention is, authoritarianism, paternalism, and then communication. So that's one of the most important things that you touched on as well. And actually learning how to communicate with people who use drugs. And you have to be very mindful if you want what you're saying to be received, or if you want people to be open with you. And so what I see a lot of times is very one-sided, to where it's like, be honest with your medical professionals, with your providers, but then it's like, is the individual you're talking to, like, what's their vibe like? First of all, I'm sorry, like, if you want to reduce it to just vibes alone, what is their vibe? Do you want to open up to them, or do they have a really bad energy and you're like, there's no way I'm going to open up to this person? So it's not just words. Like, there's like, you could have a script and have a terrible fucking vibe and people would still not want to say anything to you. So it's not just about like being informed when it comes to like, person first language and like less stigmatizing things and, labels and terms, and, just like being like mindful, of words. It also goes into, again, like I'm sorry, but just like your vibe. And then, that can kind of foster this space that, is a little bit more even when it comes to like the back and forth and exchange of information. And then then you can implement, you can bring about like informed consent, because the person is like actually listening to you and feels safe talking to you. So you're going to be a lot more effective in probably implementing whatever, seems like the most evidence-based or just like the most applicable thing for this individual, if that's where you're coming from. And so I think that a lot of the issues with my care was just like a lot of professionals having really poor communication skills. And and I think that that's a problem for a lot of people, and then it discourages them, and then they like are less likely to seek treatment. And then I think it's really important to acknowledge, before someone ever seeks treatment, stigma affects their willingness to even look into it, or to go to any sort of medical or clinical space. And so if we're talking about stigma in like the medical space, we have to like acknowledge the barriers that are really preventing people from ever walking in the doors, So it's like, we can definitely, I think it's really important to be mindful of like practices within these spaces. But like, yeah, I mean, dude, so many people don't want to be labeled as an addict or an alcoholic, and they would much rather just like die, honestly,
And that's the biggest thing, right? And that's like, if you see that the system is causing harm, then who are you missing? Because a lot of people aren't even seeking care if the system is causing harm to this community specifically, right? And so that is one of the biggest things. Like, that change doesn't happen overnight. Stigma is a sociocultural phenomenon that everybody participates in. And so everybody has a little bit of responsibility and power to change that, which is why I encourage every single person to participate in changing that. Work on changing your approach, changing your communication, just like you talked about, Macaulay, changing and yes, it's not just labels, but like the labels and terms that you use, being mindful of that, being able to use person first language and saying that they're a person with a substance use disorder, and not they're just an addict, or ever using the term junkie, for example. Even the clean, dirty paradigm of like, oh, they're clean now, like, implies that they were dirty before, or a clean urine drug screen versus a dirty urine drug screen. Like, I always say, if somebody says it's dirty, I'm like, what does that mean? Did you put dirt in it? Like, it's not dirty. There are drugs in it, right? Like, it is you could, in medicine, we say things are normal or abnormal. You could call it abnormal if you want. It's not really abnormal. It's just, it is positive for something. It's positive for opiates or meth or whatever it is that, like, or it's negative. It's not clean and it's not dirty. And people hear that, right? People, when they come in and they're prepared to be stigmatized and be harmed, and then you say things that are the triggers, right? The things, the red flags, right? The things that create the vibes. You have a physician who's like, oh, you overhear them say the word junkie, or they are talking to you about their prior urine drug screens and it was dirty, and you're like, the vibes are off now. Right? Like and so if we want to do better, it's just making those small changes, just to the way being willing to change your approach, being willing to reconsider how we talk about these things, how we think about these things, because people aren't just immediately going to come back and see that things are better. It's going to take time, and it's going to take time from gradually rebuilding trust. And that rebuilding trust is like person by person, brick by brick, rebuilding that culture that everyone participates in. And so it means getting everyone to change their perspective. And that's really hard to do, and it takes time, and I get that. And in the meantime, the hard part is acknowledging and understanding that people are being harmed by this, and not only being harmed, they're being harmed to the point that they're not seeking care, including for other things. And that is a huge problem, right? Because if they're having some sort of potentially catastrophic illness and they're like, I don't want to go to the emergency department because they're going to treat me like crap, that is a huge harm, right? So it's not just harm around like not getting care for their substance use disorder or for their drug use. It's about not getting care for everything, not wanting to go see their primary care doctor because they're afraid their primary care doctor is going to treat them like crap. Like, we want to be cognizant of how this impacts whole person care. People are people, and people use drugs. So like, this is part of caring for a whole patient. And so if we want to be able to care for the whole patient, we need to understand that people use drugs. They're going to continue to use drugs. That's never going to stop, no matter how many prohibition-based policies we put in place. And that we can reframe how we approach those patients, not how those patients come to us. That's the only way we're going to fix it, right?
Yeah,
yeah.
I think people need to understand that, I don't need to understand, but it could be helpful to understand that a lot of individuals with substance use disorders are very hyper aware, not to generalize everyone, but that's often a thing, and are navigating within these social systems and these like cultures that you need to be very protective of yourself. You need to be able to pick up on social cues. You need to be able to pick up on all this stuff. And then we put them into a room with fluorescent lights and with like a really bad vibe, and then have someone come in with like very strong, like authoritarian vibes, and like with the attempt to just like really just present like this vibe of professionalism, which is like understandable. But I just think that it's important to understand like the population that you're very likely dealing with, and that it might serve you a little bit better to be more personable and like less focused on professionalism. Like, you can engage in being professional and also like ethical at the same time, and like mindful of someone, and like just their potential history of trauma, like if we're going to project that onto everyone. But I just think that that's the missing link a lot of times, and that's often why a lot of people, they put way too much importance on like people with lived experience being in those spaces. A lot of it has to do with the fact that they can just actually communicate with someone who is in an active substance use disorder. So if you could just learn to do that without having to have all those experiences in your past, that's probably ideal, because you can like prevent yourself from you don't have to experience all these traumas. You can just communicate that way. And it doesn't have to be fake or performative. It's like totally possible to do that. And I think that, yeah, it's like look, it's normal to want to be perceived as professional, but I think that a lot of that stuff, honestly, it needs to be kind of thrown out the window, and you need to just be personable. And I think that could fix so much of this. And in closing, I'll say, you don't need to have a provider that has any lived experience at all. Like you really don't. Like especially if you're seeking out a specific like medication or like modality or protocol, like you just need to be able to communicate with them, and if they are like competent when it comes to implementing that or supporting you in doing something, then they can help you to do that, you know. And I just think that that's really important to acknowledge, like why the whole lived experience thing is like put up on a pedestal within these spaces, and a lot of it is communication and the ability to relate to someone, and you can do that even if you haven't experienced substance use disorder, you know.
Well, let's talk about that. I have not personally, I have no lived experience with having a substance use disorder. And I actually think that's part of why I'm more drawn to talk about this, is because if I did, then it's more easily written off. It's like, oh, well, you only care about people who use drugs because you were a person who used drugs or whatever.
Yeah.
And it's not that. And you don't have to have that, right? I'm able to have these conversations with my patients not coming from that perspective. And I think patients respect me at least as much for it, despite the fact that I've never, been in those places. But that's also sort of like the root of what empathy is. It's like being able to understand another person's perspective and understand their experience without having to have lived it yourself, right? And so it's just about being able to have empathy for people in this position. And I think one of the things you said, that in fact people with lived experience can cause more harm, that is true in medicine as well, because it is possible that people will share only their perspective of recovery with somebody, and that may not be the right thing to do, and it may not be the right thing for that patient. But I also think that you bringing that topic up, I think is interesting, because that is exactly what happens in recovery spaces too,
Yeah.
right? And like this, as you have sort of coined, like the lived experience fallacy, that is somehow the end all be all of like what being able to achieve recovery is, which is just not true, because people are unique individuals who have different experiences.
Yeah, exactly. You know, and like just to like put a bow on the last topic, I'll say that, you know, like when you're seeking, you know, like you're going to a cardiologist, you're not like, did this one have a heart attack? Like we need to, only go to one that's had a heart attack. Like that's just wild, dude. It doesn't, maybe there are people who are seeking that out, but I don't know. It's just you generally you don't see that as much. At the same time, on the other side of the coin, yeah, I mean, the lived experience fallacy doesn't just apply to people with substance use disorders. It's like a human thing. It's just it's a bias that you have because you've experienced something, and then it's you have good intentions because you think that you could help someone by sharing it, but then if it's canceling out all of the other options, that's the problem. And so, yeah, within the recovery space, first of all, I'll talk about the people seeking that. So it's the same kind of template. A lot of people, they don't go and seek out recovery resources or community because they don't want to be labeled as an addict or an alcoholic. And when you look at these traditional communities, it is built upon qualifying labels, identifying, self-identifying, affirming that, saying
an AA
that.
meeting, what's the first thing you do?
Yeah, that's what you know. And look, people will say, "Oh, you don't have to do it." Okay, you're not going to be accepted at the same level as someone who is engaging in that. And that's part of it. When you look at the actual steps too, like look at the first step. So it's, and what is tied to that is going to be an identity. It's going to be a qualifying label. And so that's the thing. That's why I am just so serious about these labels and these terms. And this doesn't just apply to like qualifying labels, it applies to labeling substances as addictive themselves. Like labeling substances as inherently addictive, that's the stigma tied to that. It really can prevent people from even talking about their use of that substance and minimizing the amount that they're using or the frequency of use. And that is, of course, going to affect it in the medical space when it comes to withdrawal management. That's like huge. But then when it comes to like, in a community level, it can just create this like this feeling of you're not being honest, but you don't feel like you fully can because what? Communication a lot of times. So again, we're going back to communication and we're going back to authoritarianism and paternalism. Same shit, but you find it within these communities. And so we have people who have abstained for a period of time. They value that a lot, which is, I understand that. I personally don't in my own life, but that's fine if that's what you value. And so you have that, and that's like the basis of an identity. And so that's going to create a kind of disconnect often when we're dealing with, again, very often highly intuitive people who are in these circles of communicating, usually very like, very intensely and often very directly, and trying to make sure you're not being taken advantage of, or people aren't hitting licks on you, if you will, or like, taking advantage of you. And then now you're going into the setting with like a different language basically, and you have someone who often is like a little bit can be self-righteous, and then again we have authoritarianism, paternalism, and then we have a disconnect when it comes to communicating, and that can hinder someone when it comes to them feeling safe and like they can say what they need to say. So instead of like acknowledging that within the recovery space, within communities, everything is, the fingers are pointed at the individual, and there's like almost no accountability when it comes to how are you conducting yourself as an advocate. And I understand, like, I'm not trying to be on a high horse with this because I did all of this stuff. Like I did all of it, and I can definitely myself sound like self-righteous and patronizing when I'm talking about this, because it's just wild when I started to realize what I was doing. And when I started to realize that this was actually common, and it was almost like people, it's not almost like people are being taught this and indoctrinated into this. And so, just communication can really help to avoid a lot of this. And people who are like ethical and like who aren't actively accidentally harming people, they are mindful of this, and they are going to communicate in a very compassionate yet direct way. And that's the only reason why I existed within 12-step spaces for many years, is because I gravitated towards those individuals, which were few and far between. Everyone else, for the most part, they were really embodying all of the things that I mentioned in a more negative light. And so this is a cultural thing. And and just all in closing, when it comes to like the communication aspect, which is really, really affecting this, I can say that people are not taught to communicate in a way that is more just likely to be received, because there's this language, there's these thought-stopping cliches and these sayings and stuff. And so often people go from this very intense culture within substance use, and they go immediately into that, and it's one extreme to another. So then there's no middle ground of just like learning to communicate. And I don't want to say normally, but like it's like one way or the other. Now you're just parroting stuff. And so we're really not helping people to develop communication skills. And this also creates discrepancies when it comes to communicating with people who don't have a substance use disorder, because all you're doing is like you're communicating with the script you've been given. And so this directly contributes to the stigma of not only people with substance use disorders and people who use drugs, but the stigma related to people in recovery. They're seen as like less than, in a way, and like kind of sad. Like it's like, yeah, they're just trying to redeem themselves for the rest of their lives. And then that contributes to marginalization and infantilizing people. And so you go from like being marginalized in one space to being marginalized like a little bit less. Like you're valid now, though, because you don't use drugs. Now you're valid, but still, like, we're kind of looking at you sideways. And so,
and there are two things from that, though, right? Like, so there's one of the things you bring up is like the commitment to abstinence, and that's part of your identity is wrapped up in that, and you're counting days and all that stuff creates the abstinence violation effect, right? Of like, which is a huge reason that I'm not a believer in the idea of counting days and all this. And also the idea that recovery is somehow intrinsically tied to your time of sobriety or abstinence in general at all. Um, I don't believe that you have to be abstinent to be in recovery, including from your drug of choice, but let alone other drugs, right? Like that's a totally separate thing. But I think the drug that is problematic for someone that they want to reduce their use of or stop using entirely, their recovery process starts when they decide that they want to start recovering the things that they had before they started using, things that they may have lost because of their use, right? Part of the definition of a substance use disorder is that, right, it's 11 points or 11 questions across 4 different domains. And one of those aspects is this impacting your interpersonal relationships, your work life, your social life, recreational activities, right? That is sort of part of like how are you using and how is it impacting your life. The other part is related to sort of the craving aspect of like how much time are you spending using or recovering from substances, and that can be tied into it having harms on other aspects of your life. And so if you are seeking to change those things in any way, you are starting the process of recovery, in my mind, right? Even if you are still using, but you're like, I want to get X back and I want to reduce my use so that I can be more effective in working on my relationships and restoring my relationships with people and getting my whatever life back, my job back. The process of recovery is recovering the things that you had prior to the harms that were caused to you or your community through your use. And so recovery is not defined by a date or an period of abstinence. It is by the process that you have gone through. And because it's a process, you can't put boundaries on it like that. You can't say that like you've lost your prior recovery entirely because you used again. Right? It's like it's absurd to say that like, oh, you had all of these experiences that were positive, you were working on something. Right? I can't think of another aspect of my life where I would say like, oh, I like you built a whole house and then like you decided one day to like stop working on it and you like put it aside for a while and then you go back to working on it. You didn't like you still have a house there, right? Like it's not like somebody just magically came in and took it away. Like
Yeah.
it, it's it seems silly to me that like there's no project that you work on that like you're like it up and disappeared and I have to start all over again because what? Because like you return to using whether it's once or multiple times or for a prolonged period. It doesn't matter in much of the like abstinence based sort of recovery culture. It's like, nope, you're back at day one. And that part drives me nuts because it's like, it's all about rebuilding skills and building coping skills. One of the things you're talking about is like communication. That's such a huge factor. Being able to develop your own skill set for not just for coping, but in life, in communication, in social setting that doesn't revolve around the drug of choice, the thing that is harming you is critical in recovery. And so if you are not allowing people to develop those skill sets, you are actually causing harm because those are the things people need for the process of recovery. So it is counterproductive to reduce things to cliches and to tell people that, whatever, all the things that like the whole like your disease is doing push-ups in the parking lot and all the, like you said, thought stopping cliches that are limiting people's ability to recover. To like, yes, it can help them become abstinent, but that does not in and of itself mean recover. I see those as sort of entirely separate things. And I want people to understand that in terms of like even how we named this podcast. It's like it's not about abstinence, it's about redefining recovery and that people can recover however they want. Abstinence or not, that is wholly separate from the process of recovery, and that is not defined by dates and times and whether or not you're using or how you're using. And it may mean your part of recovery may actually be that you change how you're using, but it's not defined by that. That can be part of your process. Like, you're doing a thing that harms you less. Instead of injecting, you went to smoking. That is harm reduction. And that could be part of your recovery process. That could be part of you getting to a place where you can now control the pieces of your life that you need to improve upon or want to get back or whatever it is. But those are distinct entities. And I think we need to start thinking about them separately if we want to reduce the internalized stigma and shame that people are feeling. If we want to reduce stigma in the way we view people in recovery or we view recovery communities, right? One of the things we were talking about is like, oh, you are more valid because you are in recovery, but also like now you're viewed still as less than just slightly more valid than somebody who's still actively using, right? Like, yeah. We collectively as a society, and including within healthcare, need to understand these concepts if we want to reduce stigma against the drugs that, like as you said, the way we think about drugs in and of itself is stigmatizing. So if we want to reduce stigma against drugs and the people who are using them, we have to start to understand these concepts of recovery as different and of sort of humanizing people who are using drugs and understanding drugs in and of themselves as not stigmatizing them. Because drugs in and of themselves are just chemical structures. Like, you can't, and this is sort of like a tangent, but like in terms of the words that people use, you cannot abuse chemical structure. Now, it can cause harms to you. You can abuse yourself with a drug. I'd say that's valid. But you can't. It's not sentient. You can't. It can't understand that you are like you. What are you like punching piles of cocaine? Like, what are you doing to abuse it? Right? Like, you can't really abuse. You can't physically harm, and it can't recognize. To cause something harm, it has to recognize that you are harming it. You can't harm a chemical structure. It won't understand that. So the idea of drug abuse, or there a person who abuses drugs, or even the idea of people say like they try to do better, and I appreciate that. They'll say substance abuse disorder. I'm like, well, close, but not quite, because like, and the irony is that the National Institute of Drug Abuse, with a name it's given to it, but by Congress, put out the statement of how we should reframe the words that we use in terms of treatment of patients. And one of the things that it says is to like stop using the word abuse and replace it with use, right? You can say use, you could say misuse, but not abuse. But that the name of the institute is the National Institutes of Drug Abuse, and they cannot change that name of the director of NIDA cannot just like single-handedly be like, yeah, we decided that's a bad term. We'd like to change our name. Like, they'd have to go before Congress for that. So anyways, total tangent, but like the idea that drugs are inherently the problem is part of the stigma. And we got to reframe the way, all the way back to reframe the way we think about drugs as chemical structures, because that is where we derive the stigma, or the stigmatization of people who use them is in part derived directly from the stigma against the drugs. And so we need to reframe the way we think about those in healthcare. I mean, in healthcare, we use drugs all the time. I mean, not like on a personal level for patients, right? We are treating patients with drugs by definition, whether it's for like chemotherapy, still a drug, right? Antibiotics are drugs. We need to reframe the idea that drugs are somehow inherently bad. We've decided that certain things are bad drugs and other chemical structures that we use for medications are good drugs, and that yet we use some of the bad drugs for helpful reasons in medical settings, and yet somehow they're still the bad drugs. Like, we use ketamine and fentanyl. And like when people sort of mischaracterize fentanyl as somehow evil, it drives me nuts, because there's nothing inherent about that as a drug that is a problem. We use it. I use it all the time. Probably every day I work in the emergency department. I use fentanyl as a medication because when people come in with trauma, it is fast acting and it is very effective. That's what we need in those settings. The dose makes the poison, and what we have is an unregulated supply that is dangerous, that people are overdosing and dying from. We should acknowledge that as the problem. The drug itself is not a problem. Use it all the time safely. And so it's the stigma that's derived from the concepts of prohibition that causes a stigma of the drugs that also perpetuates stigma on the people. And that applies to healthcare spaces and recovery spaces. Both.
Yeah. Yeah.
And internalized shame around that. That stops people from seeking care, that stops people from seeking recovery spaces, that keeps people held hostage to the idea that they cannot escape. And stuck in the cycle of internalized shame. That is problematic.
Very true. No, it's very relevant. I think that it's not maybe a tangent, but it's a relevant one, because we're, when we're looking at, specifically recovery communities, just tying it back to that, is you see like the personification of substances and the personification of substance use disorders. And, this creates this kind of sensationalized narrative, when it comes to substance use disorder, alcohol use disorder, and just specific substances. And so this form of stigma it's implemented often as like a preventative measure. Like it's like a thought exercise that people engage in. It's really, they're indoctrinated into it. They're not just like choosing to engage in that out of nowhere. They're taught this. But I think that it's really important to acknowledge like the effect that has within just the recovery space as a whole, which, we're talking about treatment industry, recovery communities, things like that. And, I think a lot of people, their intention is to really just put that into a box, put their substance use into a box that can then be stamped with something that says invalid. This is not valid. This is dangerous. This is scary. This is evil. This is demonic, and then often that can help people to kind of stop entertaining it. And so I get it. I understand why people do that. I did that myself. The problem is how that then translates to, harm, specifically of people who use drugs. And so that's another thing that I think is like super relevant within these recovery communities and within treatment, because again, people are given this script and they're just like kind of regurgitating it and putting it out there. And again, that kind of prevents people from learning how to find their own way of talking about this. I encourage everyone out there, like, find your own way of talking about it. Like, really just sit with yourself and let yourself say just like word vomit and just like see what comes out and try, just try to speak authentically based on like what you truly feel, because that's going to be very helpful, is to learn to talk a lot, honestly. And it's the opposite of what you're told within these spaces. And that's another kind of point of stigma, is that there's this idea that like you're valid with time, and if you're new, then you should shut the fuck up. You should shut up. Like, that's literally, they say, like, take the cotton out of your ears and put it into your mouth. And it's like, no, like, those are the individuals who should be talking the most. And, tying it back to what you were mentioning as far as time, like, look, time in recovery does not translate to you being, a good person or like ethical or like educated on any of these topics. It just doesn't, like, and I understand time. Like, I sound so patronizing throughout this whole episode, but like, this is where I'm at authentically. But the point is that like, there are people that are brand new to their own recovery process, and they have really profound things to say, and they have really great things to add. And we should be talking to them and referencing them when it comes to how to actually change policy, how to change different protocols, how to, sculpt their, like, encourage them rather to kind of sculpt their own process, and to kind of, you can create different protocols through communicating with people who are in that space currently and that are seeking to like find their own kind of route. So it's not just people who are actually have a little bit of time that are valid. It's actually people who have none at all and are actively using. And and I think that that's just not a thing. It's like it's missing, and that's where I get the best information from. That's where I hear the most profound things from. And I just kind of want to give people who use drugs their flowers, and people who are like, looking into their own process, and they have a lot of really good things to say, generally speaking. And I that's what I've seen and experienced, and when we stigmatize people and tell them to shut up, then yeah, that's not really encouraging for, we're not encouraging them to talk. And that's a huge missing link to where we just have, literally, honestly, we have people in recovery, often abstinence-based recovery, who are acting as the spokespeople for people who use drugs, and they're doing it from this place of stigma and bias. So then it's like, what is that doing? That's influencing us on a cultural level. And then guess what? We'll also bring those people in when it comes to like speaking speaking to Congress, speaking within these institutions. And so we have these spokespeople who are like the worst fucking people to ever talk about this, because honestly, they themselves have been marginalized. And so, I'll kind of like pull it back a little bit here and like rein it in, but like that's a huge problem when it comes to this stigma within these recovery spaces. Is like we're putting people up on a pedestal based on time and abstinence, when like they often just they shouldn't be speaking for anyone else. And that's where you see this culture of like making we and us statements and generalizing people. And there's literature within these traditional spaces that's what is filled with, is these like generalizations, and that you're spiritually sick and you have the threefold disease. And it's just like, dude, this manifests so many different ways. It is like a spectrum, a very, very broad spectrum. And I'll like wrap this rant up by just saying, like, dude, there are people who stop using substances, and all of a sudden, like, they have like a profound change without anything, without any like, I'm constantly working on myself or whatever. Like, they just, something happens to them and they have a profound change. Now, guess what? There are also people who don't quit using completely, and the same thing happens. Like, they have this thing that just shifts, and it's like really beautiful. And it's not through a specific modality or working on yourself. So like, that's something that has been fresh on my mind, is that the stigma of what is healing, what is recovery, what is valid, what isn't. And it's like, not only is like the demonization of substances harming people, but like to dictate what a recovery process needs to be for someone, is that's a huge problem, because it often is like really invalidating for people who are already in a much better position. And it creates this dynamic of like, or there's this way of thinking that you need to get to the point of then being legit and valid, when you might already be there and you may still be using.
And as long as that stigma exists in society around using drugs, people who use drugs still actively cannot, are putting themselves at risk to speak up as the voice of people who use drugs, right? So you end up with people who are not using drugs, who are in recovery, but then have been indoctrinated into harmful sort of narratives that marginalize people who use drugs, to then speak for people who use drugs, which is inherently problematic, right? And so I admire people who still actively use drugs, who speak up as advocates for, drug users, drug user unions, and that sort of thing.
Yeah.
But I acknowledge that is a difficult position for someone to put themselves in. And so I respect the fact that people are not going to do that. And so there aren't going to be enough advocates for people who use drugs that are actively using themselves. And so you are going to end up with sort of these misplaced, misguided narratives instead. And so until we address that stigma, this will always be sort of putting things backwards. And it's interesting thinking about that, to what you said, Macaulay, about putting things backwards and not having people who are newly in recovery not speaking, while those might be the people who we would learn the most from. And in fact, those are the best people to speak to, because recovery is individual, and we should be advocating to help support people getting into recovery to find their unique balance of how they want to recover and helping them. So having more time doesn't make you an expert on someone else's recovery, because their recovery is unique, and you should be listening to them to support them in what their process is and is going to look like in meeting their goals. And so that is exactly where the paradigm does need to be flipped on its head, and where harm reduction is inherently an individualized notion, right? You have to meet people where they are. That is inherently an individual work. And so it is the antithesis of this one-size-fits-all top-down approach that is, the things we were talking about in terms of healthcare, in terms of recovery communities that are causing, perpetuating stigma. Both of those share those traits. They're very top-down. They're very paternalistic, like you said. And it is that we need to flip those paradigms to put the person who is the patient or is seeking recovery in the center of that paradigm and focus everything around that. They're the people who should be speaking. They're the people who should be focused on. They're the people whose narrative should be listened to understand how to help them. And it is the exact thing in doing that we will be able to address the stigma, and if we are able to flip those paradigms, if people are mentally able to make that shift, then we will be able to address the stigma. It will take time. It is one brick at a time, right? But we do have to build this. We have to make it better, and we have to create change. And some of that is from the bottom up. It is advocacy. And some of that is from the top down. It is a policy level work to do the advocacy at a policy level to change the way we frame drugs themselves, right? Because some of the stigma starts with the stigmatization of drugs and the way we have put things into scheduling, which we can do an entirely separate episode on the history of drugs and the way they were scheduled and the reasons for it. But that is all inherently problematic and has a problematic history that we need to, as a society, revisit, and on a policy level need to change. And so I think we can and should, as a society, approach it from both sides. And we need the advocacy on both ends. We need patient advocates. We need advocates for people who use drugs. We need advocates on a policy level to be able to change all of these things to address that stigma. And we can do that. And it takes everyone. And so I think, sometimes people get frustrated, like, oh, well, I can't change policy. Well, you can change the way you talk to people. You can change the words that you use. You can look into this for yourself. And just doing that helps to change this phenomenon of stigma. Every person's mind you can change helps change another. You create a ripple effect. And that will help us get there. That will. And we will help, improve healthcare, recovery spaces, and the lives of the people who are actively using drugs, which really, in the end, you and I have both talked about, that is the center of the focus here, is the most valid people are the people who are still using drugs. And everybody else is lower on the list, because those are the people we need to focus on. That's the way we need to flip that paradigm and focus on people who use drugs and what they need, so that they can access the care that they need, they can access recovery how and if and when they want to, and so that we can move forward and save more lives. Overall in healthcare, that's our goal, right? We want people to feel comfortable coming to us so we can help them, so we can improve their lives, so we can save their lives, so we can help them live longer and healthier. And we can't do that if we're stigmatizing them. And you can't do that in recovery spaces if you are shaming and stigmatizing and making people internalize that shame and that stigma even more. And so that goal, sort of from both ends, is sort of aspirational, but I think we can get there. We just need people to be willing to do the work.
Agreed. Yeah, I think you brought up something that's really important, and I'll kind of touch on this, and then we can, I guess, wrap it up if you're down. I think that I can just speak for myself that I had a lot of anger towards substances in general, because again, I was looking at them as if they were sentient and as if they were out to get me, and then just looking at substance use disorder like that, and then having anger towards myself. And I think that it can be really helpful to like look at that anger, because that usually is the fuel that justifies stigmatizing not only yourself but others. And I think that we see this a lot with family members who have been traumatized. They have trauma around their relationships with people who have substance use disorder, alcohol use disorder. And it's normal to feel anger and to be resentful, and to be in a trauma response. It's totally okay and normal, but I can say that as soon as I started looking at that, expressing legitimate anger in a healthy way, and not using words as daggers against myself and other people, that my advocacy changed drastically. And it just ties into exactly what you're saying, is that it's all just on a personal level. And then you can also be super condescending like me, and like make statements that are like patronizing people who I'm viewing as stigmatizing. You can do that too. It doesn't always work though. So like, this is my real, like, less kind of like salty take, is just like, look at, you can look at yourself and look at your own anger, and how that usually is often fueling the entitlement to be stigmatizing. Is like, it's usually rooted in that, and it can be covered with other things, and I'm sure there can be other underlying emotions that are more dominant for other people, but ultimately it's like, you're not gonna like be mean to someone at the point that you help them. Like, it's you can be very direct, and I'm actually all for that, being like very, very direct with people, and not BSing them, and just like, being very honest with them. But the truth is like, we don't need to often like advocate from a place of anger. It doesn't work. And it ties into the paternalism, and it's like, it's normal for people to have that response though. So like, again, I joke around, and I like, I throw these kind of like really kind of harsh statements, but the truth is like, we can operate with love towards people. And like, I have to take my own advice often, because it's like, ultimately we are dealing with, if we're talking about people in recovery, with someone who's been marginalized themselves, and is, often like has actively been put into a state of subservience. And if I like go into it with this like this over the top vibe, it's like, often that's not going to be received, and so that itself, is like not always effective, so I just wanted to acknowledge that, because just I get very passionate about these topics, and I'm aware of like what I sound like, and I'm aware of like where, how I can be perceived with this. But I just want to give an open invitation to anyone who like sees this stuff and they're like, "Ooh, that kind of maybe applies to me." I always will have a respectful, loving conversation with anyone who feels like maybe they're partaking in some of these things that we're like kind of warning people about, or like cautioning against. Is that you can always look at it and change it, because we're both a testament to that, like going from one side of the spectrum to the other. And yeah, it's available for anyone who's interested in kind of shifting their advocacy.
I was gonna say, you and me both, brother. You and me both. We're both passionate, and I can understand how it can come across at times, but I am very open to conversations. And I think, again, this building is built one brick at a time, and we can have those conversations to help us get there. I'll close with the fact that if you were punching piles of fentanyl, you still will not overdose. You cannot overdose from touching fentanyl. So I just had to make that clear. Anyways, I appreciate all of you. Thank you for watching or listening. We'll see you next time.
Views and opinions discussed on this podcast are personal and do not reflect the views or opinions of our employers. Although medical and clinical topics may be discussed in this podcast, the information provided is not medical nor clinical advice. Thank you for watching and or listening.